Okay, let's dive right in. I'm really looking forward to this deep dive because we're looking at something incredibly important, a clinical trial focused on, well, a specific group of patients.
Exactly, a group that often doesn't get the main focus in those big cancer studies.
Right, we're talking about advanced non-small cell lung cancer, NSCLC, and immunotherapy. It's really changed things, hasn't it?
Oh, absolutely. For many patients without those targetable mutations, it's the standard now.
But the issue is patients who are older, say 70 plus, or those whose physical condition isn't quite as strong, what's the term? ECOG performance status 2?
That's the one, ECOG PS2. And yeah, those groups, they haven't been well represented in the big trials that set that standard of care.
Which leaves a real gap, doesn't it? Like, how do you know how well these treatments work for them?
Precisely.
Yeah.
You need data. Clinicians, patients, they need to understand the benefits, the risks, the tolerability in these specific groups.
And that's where our source comes in. We've got this paper on the GFPC 08-2015 Anergy trial.
Yes, a phase 3 study. And it was designed specifically for these older or less fit patients.
So our mission today, let's unpack it. What did Energy find? What does it really mean?
And maybe crucially, what are the nuances? Because, the subgroups tell quite a story here. Some surprises, maybe.
Okay, let's set the scene first. NSCLC, huge cause of cancer deaths, we know that. And immunotherapy, first-line standard for many now.
Right. And this trial looked at a specific combination, the nivolumab. That's an anti-PD-1 antibody. It sort of wakes up the T cells to fight the tumor again.
And it was paired with ipilimumab, that's the anti-CTLA-4 one.
Yeah, it works a bit differently. The idea is it helps generate new T cell responses against the tumor, boosts the memory cells too.
So complementary mechanisms, you combine them hoping for a better, maybe longer-lasting effect.
That's the hope. Increased long-term survival, ultimately.
And they compared this combo against what was the standard before these became so widespread?
Platinum-based doublet chemotherapy, so carboplatin plus either Pemetrexed or paclitaxel. That was the control arm.
Now, you mentioned this combination, Nivo plus EPI. It had already shown promise, right? In Checkmate 227.
It had, yes. Showed it was better than chemo in that big study. But, and this is the key point.
The patient population was different.
Exactly. Median age 64 in Checkmate 227. Mostly ECOG, PS0 or 1. Fitter patients generally.
So Energy deliberately went after the gap, patients 70 or older, or younger patients, but with that ECOG PS2 status.
Correct. As long as they were still considered okay enough, fit enough to get carboplatin chemo.
Okay, so it's a phase 3 trial, randomized, open label, conducted in France.
Yep, multi-center, stage IB, NSCLC, no common targetable mutations.
And the randomization, 1-to-1 immunotherapy combo versus chemo, they tried to balance the groups.
They did. Stratified by age under 70 versus 70 plus, by performance status 0, 1 versus 2, and by histology, squamous versus non-squamous. The usual.
And the treatments, how long were they given?
Immunotherapy was basically until it stopped working, or side effects were too bad, or the patient chose to stop, or up to 2 years, though they could potentially restart it later.
And chemo.
Up to 4 cycles, standard approach, maybe some maintenance therapy afterwards depending on the specific drugs used.
Got it. And the main question, the primary endpoint?
Overall survival. OS, that was the big one.
Secondary endpoint.
Usual suspects. Progression-free survival. PFS, how long until the cancer grows. Objective response rate, ORR tumor shrinkage. And of course, safety, always crucial.
Okay, so how did the trial actually go? It started in 2018, planned for quite a few patients.
Yeah, about 242 patients over, 42 months or so?
But it didn't quite go the full distance, did it?
No, and this is really important. The trial was stopped early.
What?
For futility.
Yeah.
Not for amazing success, unfortunately. There was a pre-planned look at the data, an interim analysis, back in late 2019. And based on that, after about a third of the expected deaths had happened, the committee concluded there just wasn't enough evidence emerging that the immunotherapy combo was going to beat chemo in the overall group.
And they mentioned specifically the ECOG PS2 patients.
Yes, the signal looked particularly weak, maybe even negative in that subgroup at that interim point. So the decision was made to stop enrollment.
So the final number of patients analyzed was lower than planned.
Right. 216 patients in the end.
Yeah.
109 got immunotherapy, 107 got chemo. Pretty balanced still.
And who were these patients? What did the final group look like?
Median age was 74, so definitely older overall. And 79%, nearly 4/5, were 70 or older, just as intended.
And the performance status?
37% had ECOG PS2, so a good chunk were in that less fit category. Though, interestingly, even within that PS2 group, the median age was 69. So it wasn't just the very elderly who had poorer PS.
Okay, so based on those 216 patients, what was the main result? Overall survival for everyone combined.
Well, numerically, the median OS was longer with immunotherapy, 14.7 months versus 9.9 months for chemotherapy.
Okay, that sounds better.
Numerically, yes, but the hazard ratio was 0.85,
Huh.
and the 95% confidence interval went from 0.62 up to 1.16.
And that confidence interval crossing 1.0 is the key statistical point, right?
Exactly. Because it crosses 1, it means the result wasn't statistically significant. The p-value is 0.298. So for the primary endpoint, looking at the whole group, the trial didn't show a statistically significant benefit for Nivo plus EP over chemo.
Despite that nearly 5-month difference in the median.
Despite that difference,
Yeah.
the variability was too large or the effect size not consistent enough across everyone to be statistically convincing in this overall group, especially perhaps because it was stopped early.
Okay. What about the other efficacy measures? PFS, response rate, for the whole group again.
Similar story, really. Median PFS was also numerically longer with immunotherapy 5.5 months versus 4.6 months.
But again, not significant.
Not quite. The HR was 0.75, confidence interval 0.56 to 1.01. That p-value was 0.061, so very close to the traditional 0.05 threshold, but technically not significant.
And response rates. Did more tumors shrink with immunotherapy?
Actually, no. Very, very similar. ORR was 38.1% for immunotherapy, 40.0% for chemo. Basically the same.
So if you just look at the overall results, the headline is kind of negative. The trial didn't meet its main goal.
That's right. Based on the primary endpoint for the entire study population, it was a negative trial.
But like we said at the start, this trial was designed because the overall population isn't always the right focus for these specific patients. Did the picture change when they looked at the subgroups?
Ah, yes. This is where it gets really interesting and I think provides the most valuable information from Energy. Analyzing those planned subgroups, especially by performance status, tells a very different story.
Okay, let's break that down. First, what about the older patients age 70 plus who are still relatively fit? ECOG, PS0 or 1, what has been there?
Right. In that specific group, median age was 76. Remember, the difference was pretty dramatic. Median OS with immunotherapy was 22.6 months.
Wow. Okay. And with chemo?
Only 11.8 months, so nearly double.
And the stats, hazard ratio.
HR was 0.64.
Yeah.
And crucially, the 95% confidence interval was 0.46 to 0.96.
And that interval doesn't cross 1.
Exactly. Which means, for this subgroup of fitter, older patients, the trial did show a statistically significant benefit for the immunotherapy combination compared to chemotherapy. A really substantial difference.
Okay, that's a huge contrast to the overall result. Now, what about the other key group? The patients with ECOG performance status 2, these could be older or younger, but all shared that poorer PS, median age 69 in this group.
Well, here the results flip completely, and it's quite stark.
So,
Median OS with immunotherapy in the PS2 group was just 2.9 months.
2.9, that seems very low.
Is very low. Compare that to the chemotherapy arm of the same PS2 group.
Yeah.
Their median OS was 6.1 months.
So immunotherapy was numerically worse in this group.
Numerically worse, yes. The hazard ratio was 1.32, meaning a 32% higher risk of death with immunotherapy in this subgroup, though the confidence interval was wide, 0.82 to 2.111, so this wasn't statistically significant either way.
But the trend is clearly pointing in the opposite direction from the fitter, older patients. Not just no benefit, but potentially harm.
The data certainly suggests that. The signal is concerning for immunotherapy in the ECOG PS2 population based on this trial. It really highlights that grouping all older or frail patients together is problematic.
Did they look at other subgroups like just age overall or histology?
They did, but when they just split by age, 70 versus A70 overall, or by squamous versus non-squamous histology, or by PD-L1 levels across the whole group, they didn't find statistically significant differences in OS between the treatment arms.
So the real differentiator seems to be that performance status, especially the contrast between the fit older group and the poor PS group.
That's exactly what the data points to. The combination of age A70 and good performance status 0-1 versus poor performance status 2 revealed these opposing outcomes.
This is fascinating. The overall trial stops early for futility, looks negative. But dig deeper and you find this potential major benefit for one specific group and a warning sign for another.
It really underscores the importance of designing trials for these populations and analyzing them carefully. It's not a simple picture.
Let's talk about safety then, because you might think, okay, maybe the immunotherapy was just too toxic for these older or less fit patients. Was that the case?
Well, looking at the overall rates of side effects, it's interesting. The immunotherapy combination actually seemed generally better tolerated than chemotherapy in this population
Mm.
based on the reported rates.
Really? How so?
Fewer patients on immunotherapy had any treatment-related side effect, 74% versus 89% for chemo.
Okay. What about the serious ones, grade 3 or worse?
Same trend, lower rate with immunotherapy. 31% had a grade 3 or worse event, compared to 50%, half of the chemo patients.
So chemotherapy was actually causing more severe problems overall in this group.
According to this data, yes. The most common severe issue with chemo was neutropenia, low white blood cells in 27% of patients.
And for immunotherapy, what were the common severe issues?
It was more the things you expect with immunotherapy. Gastrointestinal, things like colitis were most frequent at 11% grade 3 plus CALH. Also cardiac issues at 10% and endocrine problems at 5%.
And the specific immune-related adverse events, things caused by the immune system being activated.
Right. Those occurred in about 31% of the immunotherapy patients, which is kind of in line with expectations for this combo. 0% in the chemo group, naturally. Things like colitis, autoimmune lung issues, hypothyroidism were mentioned.
Okay. Now, the paper mentioned treatment-related deaths. Given the patient group, this seems really important.
It does, and the rates were higher in energy compared to, say, Checkmate 227, which studied a fitter population.
Yeah.
Treatment-related deaths occurred in 10% of the immunotherapy group and 4% of the chemotherapy group.
10% is quite high for immunotherapy-related deaths.
It is. The authors suggest this likely reflects the underlying frailty, the comorbidities, of the patients enrolled in both arms of this specific trial. It highlights the challenge of treating this population.
And quality of life. Did patients feel better on one treatment or the other?
The results there were sort of neutral. No major significant differences between the groups on most QOL scales looked at.
Any trends?
Maybe a slight trend, suggesting patients felt their general health improved a bit in the immunotherapy group, while it stayed stable in the chemo group, but nothing definitive.
Okay, so let's try and synthesize this. What's the big picture takeaway from the energy trial?
Well, I think what's really fascinating and important is how this study, even though it technically failed on its primary endpoint for the whole group, gives us such critical insights.
Insights into these specific populations that often get left out.
Exactly. It shows these trials are feasible, even if challenging. Look at the higher death rates, for instance. But we need this data.
So, implication 1. The Nivoipi combination didn't show a clear overall benefit across this mixed older frail population compared to chemo.
Correct. That's the top line finding.
But implication 2, that strong signal, that potential doubling of OS in the fitter older patients, the ones aged 70 plus with ECOG PS01, that's a really key finding, isn't it?
It absolutely is. Even with the caveat that the trial was underpowered for subgroup analyses due to early stopping, that signal is hard to ignore. It suggests this combo could be very beneficial for that specific group. Needs confirmation, of course.
And implication 3, the flip side. For patients with ECOG PS2, this immunotherapy combination looks like, well, probably not the right choice.
Based on this data, yes. The numerically worse survival compared to chemo is a major red flag for using this specific combo in PS2 patients.
It really makes you wonder why performance status is such a strong dividing line here. Is it just that PS2 patients progress too fast for immunotherapy? Or is it comorbidities, tolerability?
The study doesn't answer that definitively. It could be multiple factors. Maybe their immune system is less capable, maybe they can't handle the treatment, maybe the disease biology is different or just too aggressive. We don't know for sure from this alone.
And we have to remember the limitations, right? The early stopping for futility is a big one.
Huge. It means the study lacks statistical power for firm conclusions, especially on secondary endpoints and those crucial subgroups. That significant finding in the fitter older group needs validation.
And the inherent variability in assessing ECOG status, too.
Yes, that's always a factor in trials, using it as a key criterion.
So the final thoughts are really about the need for more trials like this, focused on specific populations.
Definitely. Dedicated trials in older patients and patients with poorer PS, and critically, analyzing results based on these nuanced characteristics, not just lumping everyone together. Performance status seems key here.
So what does this all mean for you, the listener? Well, this deep dive into energy really shows that a promising treatment might not work for everyone labeled older or frail.
Right. But it might offer a really significant advantage for a specific slice in this case. The older patients who are still relatively fit, ECOG 0 or 1.
And just as importantly, it suggests that for those with poorer performance status, ECOG PS2, the older standard chemotherapy, might actually still be the better option based on this evidence.
It tells us that older or frail just isn't specific enough. You have to drill down into the details, like performance status.
So it highlights why understanding the details of studies beyond just the main conclusion is so important. Looking at who was studied, how different subgroups responded, the limitations, that's where the real learning often is.
Absolutely. Asking who is this treatment actually for, based on the evidence we have.
Exactly. And maybe a final thought to leave you with. Does performance status primarily tell us about a patient's general health, their resilience, their ability to tolerate any treatment, or does it somehow specifically predict whether their immune system can be successfully rallied by immunotherapy?
Or is it a mix of both? And how can future research get better at teasing these factors apart to really personalize treatment for everyone with advanced lung cancer? Something to chew on.